Hey guys, welcome back to another Facebook Live broadcast. My name is Sarah King. I'm the founder of Invigorate Physical Therapy and Wellness here in Austin, Texas, which is a physical therapy practice 100% specialized in helping people like you who have been diagnosed with Parkinson's create their own personalized Parkinson's plan of attack. And one of the areas we talk about in your plan of attack is this area of supplementation with strategies that go beyond the pill bottle. And we are going to be diving straight into one of those supplemental strategies today with a really special guest. So if you have heard rumors that medical marijuana may be helpful for your Parkinson's symptoms, or maybe you've seen videos online in some capacity of people smoking cannabis and having a reduction in their symptoms, like their anxiety or their tremor, or maybe you're just skeptical or curious, depending on where you're at, about cannabis or medical marijuana and how it may fit into your Parkinson's plan of attack, I want you to stay put because I have a really special interview for you today with Dr. Michelle Sexton. And Michelle is a naturopath, a functional medicine doctor, professor, and a researcher in San Diego who specializes in helping her clients fine-tune their endocannabinoid system. She'll tell me later if I said that right. And educates her clients on how to incorporate medical marijuana into their treatment strategy for any chronic diagnoses. So I am really excited to bring her on. I'm going to do that in a moment. But as we go through, some of you have submitted questions about cannabis and medical marijuana, and I have them ready to go for Michelle. But if you have questions during the broadcast about cannabis, put them in the comment section, and we will make sure to address them at the end. So say hi. Let me know where you're tuning in from. It looks like Debbie's in here from Montana. Teresa. Welcome, guys. Aline from Connecticut. We've got Sharon, as always, from Montana. Welcome back. Bonnie from Newfoundland. We've got Joyce from Colorado. You guys, oh my gosh, so many people already tuning in. Margaret from Kansas City. Wow, we've got so many people who are interested in this topic. Charlotte from Arizona. Holy moly, Alyssa from Jersey. We even have someone from Israel. So obviously this topic is one that people from all over have, and I'm so glad you guys are here. If you, during the broadcast, like or dislike or want to interact, you can comment as always. You can feel free to share this as we go, because I know that if you guys have questions, somebody you know also has questions, and Dr. Sexton is an amazing, amazing resource. And so let's go ahead, and without further ado, I'm going to bring her on here and say hello. There she is. We'll zoom in. There we go. Hi, Michelle. How are you?
Oh, I'm excellent. How are you today?
I'm doing so good. I'm so excited to have you on. I told you earlier that I've been nerding out about this topic and learning so much more than I thought that I actually would in preparation for this interview. So I have plenty of questions. And as a pretty big newbie to this world, I love to get kind of all of my definitions straight and get the framework around what I'm about to learn. And I know there are a lot of people watching who also are very new to cannabis, medical marijuana, the endocannabinoid system. Did I get it that time?
Yes.
Nailed it. Okay. I'm sure that I will butcher it later, but I want to ask you, before we dive into your background and why the endocannabinoid system is the specialty of your practice, maybe you could walk us through just some basic definitions so that everybody watching is on the same page. Does that sound good to you?
Yeah, I think that's a good start.
Okay, so let's just start with this tongue twister first, the endocannabinoid system. Can you walk us through what that is and why it's important?
So if you break down the word endocannabinoid, so endo means within, and then cannabinoid is coming from the name of the plant, cannabis. So it could also be endocannabinoid, I guess. There's different ways to pronounce it. And so this is a system that we consider a complete system in the human body. So what that means is that our body is making some compounds. So we have enzymes, we have the machinery to make compounds. These compounds then have an action within the body, and then they get broken down and recycled. So that's a biochemical system. And it got named after the cannabis plant, the same way that our endogenous opioid system got named after the opium plant. So the opium poppy. So we found the compound that bound to a specific receptor in the human body, and that compound was THC, coming from cannabis. And we found a receptor that got named the Cannabinoid One Receptor. So it's often just referred to as CB1. So I might say that, CB1. And that really fits strongly with THC. And then there was another receptor. This is another protein in the body makes called CB2. And THC also binds that CB2 receptor. And so that's how the plant, and that compound specific to the plant, has a major action in the human body. So that's sort of the connection between plants and humans.
Wonderful. And so something that I had to make a differentiation in my mind whenever I was learning about this topic was our body produces our own cannabinoids. Mm-hmm. And then there's also, right, the ones from plants. And so we're going to talk about CBD and THC, which are the plant-based. So maybe you could talk to us a little bit about what CBD is and what THC is and how it interacts with that system.
So both THC and CBD, and you might know these as, most people know THC as THC. Often you hear CBD also called cannabidiol, which is its full name. So these are, shorties. And the plant is making these along with hundreds of other compounds. And this class of chemicals made by a plant that we call cannabinoids is pretty unique to cannabis, although there are a few minor exceptions. And they're made in the part of the plant that's also making the essential oil component of the plant. So the essential oil is, everybody's usually pretty familiar that cannabis has a strong aroma. And so, these are in little goblets that are like right on the edge of the leaf of the plant. Just so like the essential oils, they can be released into the air. And that's what makes them easy to inhale and really absorbed into the body. So THC has been really the major one that we have studied and that we know a lot about, even though CBD was actually identified back in 1940, and THC wasn't isolated and identified until 1963. So even though we knew about cannabidiol for a long time, it wasn't being researched because they didn't find it to be the active ingredient. Everybody was trying to find out what is this compound that makes these really strong effects from the cannabis plant. And they kind of ruled CBD out because it doesn't really have any what we call psychoactive effect. So they're very similar compounds. If you look at their chemical structure, they're kissing cousins. They're almost identical. But if you look at their pharmacology, they really have no similarities. And so when I say pharmacology, I'm talking about specific action at specific receptors in the body. And so that's really the big difference, is that THC is really primarily acting on our endocannabinoid system, and CBD really is not. So it may be a minor action of CBD to modulate the endocannabinoid system, but it's a major action of THC. Okay,
that's awesome. That's a great explanation. And we're going to dive more into how CBD and THC affect the body and symptoms and Parkinson's and all that here in a second. But the last definition I would love to hear from you that seems simple to some, but maybe some of us need, and I'm in this class, right? I'm learning just as much as everybody else here, but maybe you can differentiate cannabis from medical marijuana from hemp.
Okay. So they're really all the same thing. That's the easy answer.
Okay.
The difference is in what we call their chemotype, or their overall chemical composition. So it's just like cousins again. And I like to use the analogy of peppers, because everybody knows peppers. And so think of just your nice, ripe, red bell pepper. And it's just sweet and juicy, and you know you're not going to get burned by it because there is no ingredient that makes it hot. That ingredient in peppers is called capsaicin. So you could think of hemp as that type. Hemp is the red pepper variety because by definition and by law of our federal government, hemp has to have less than 0.3% THC. So there's really not enough of it there to be spicy. Okay. And then if you go all the way to the other end of the pepper spectrum, you would get something like a ghost pepper or a habanero, where it is so hot that few people can even eat it. And so we have cannabis chemotypes that could be similar, where they're extremely high THC content. So they've been bred over decades and decades and hybridized and selected for mutant THC producers. So a lot of the recreational cannabis is more toward that end. And then you have things all across the middle, where you have chili peppers that can be kind of spicy, but not too spicy. And so this would sort of reflect a spectrum of ratios of CBD on the one end to THC in the other, and then right in the middle would be a 1-to-1 ratio.
Wonderful. That's a great visual. I'm picking up what you're laying down. Okay, so maybe now we can move into a little bit more about you. You have a practice in San Diego. I told everyone about a few minutes ago. So tell us a little bit more about your background and how you got into treating the endocannabinoid system.
Well, I really started my healthcare journey as an herbalist. And that was when I was very young. I got interested in herbs, so like 40 years ago, and became a midwife. This was I lived in Texas. I was from Lubbock, Texas. So was just doing home birth midwifery, providing herbal care to my clients, and knew that there was a need for more. And so that's when I got interested in naturopathic medicine. So I moved to, I had also gone back to school late in life at age 40 and got a degree in horticulture because I really wanted to study botanical medicine. And then that was kind of the door that led me to cannabis. It was very serendipitous through a connection at the University of Washington. Once I got to Bastyr to keep doing research, and found Dr. Nefi Stella at the University of Washington, and his lab was studying the role of this endocannabinoid system in neurodegeneration and neuroinflammation. So we were really, focused on diseases of the neurological system and how did this endocannabinoid system have a role. Primarily, we were looking at multiple sclerosis. He didn't have funding for Parkinson, but brain tumors, multiple sclerosis, and seizure were the main things we focused on in his lab. So I was there for 6 years. And at the end of that time, naturopathic doctors in Washington were added as practitioners who could recommend cannabis to their patients. So it was just very much a natural extension of, what I had been doing in research. So yeah, it just kind of all came together where I knew all of this pharmacology and biology of the endocannabinoid system. And then I opened the first cannabis analytical laboratory in Washington State, and then started seeing patients. So it's really just been, a synthesis of all of these things that have, provided me the background for what I do now. And so now I am a professor at UC San Diego in the Department of Anesthesiology. And so they really brought me into the department to help further this education, and to bring the clinical piece of it, specifically to the pain department. But it's really the interest, as you probably know, and many of our viewers today, people with all kinds of medical problems, diagnoses, symptoms are really curious about this because it's being widely touted as a cure everything. You could think of snake oil is the analogy that, it's good for everything. So I think it's a bit of a myth. So we'll do a little bit of myth busting today.
Yeah, I think that's probably the most important thing that I find. I'm hearing a little echo. I don't know if that's just me. But anyway, let's see if I can switch this around. All right, so here? I am. Are you there?
I'm here.
Okay. Doing a little tech. Can you see it? Okay, I can see you. All right, a little bit of tech snafu. But I think that's the biggest thing for these Facebook Live broadcasts is just to have a consolidated place to ask questions and become informed so that you can make your own decisions and not have to rely on, your neighbor's opinion of what their, experience was with medical marijuana or CBD. So hopefully this will be a good resource for everyone. And I know that you work with clients to address their entire, we're going to call it the ECS. From here on out, everyone, the Endocannabinoid System is ECS. It's just the general system. Do you work with your clients on other strategies besides medical marijuana to fine-tune their ECS? Or yes. Okay, tell us a little bit about that.
So when the patient comes in, my evaluation has really become sort of about the endocannabinoid system because it's in every tissue in the human body. It's a homeostatic system. So there's implications for almost everything that our body does and even how we feel and maybe even how we think and our moods. So there was a description by a researcher whose name is Vincenzo De Marzo, and he described the endocannabinoid system as one to provide that we eat, sleep, relax, forget, and protect. So I've kind of co-opted that into my assessment. And so I'm asking people about all of those areas of their life. And sleep being really, really top. And probably Parkinson patients know this already. And sleep is a huge issue and one that can be well addressed. Eating sometimes is a problem, everything from digestive issues to lack of appetite, weight loss, irritable bowel, so just asking about all of that. Relaxing, so stress levels. We know the endocannabinoid system modulates our ability to respond to stress. Eat, sleep, relax, forget is the next one. So we know that this endocannabinoid system and that CB1 receptor is everywhere in our brain. It is the most highly expressed protein of its class in the human brain. And it's really dense in the basal ganglia, which is the part of the brain that we focus on in Parkinson's. And so that's why it's made it an interesting target or thing to think about in terms of addressing Parkinsonism. And then forgetting could also have to do with cognitive decline with age. There's interesting data coming out about that. And then protect, I'm really thinking about the immune system and how the immune system can just go awry in so many ways and in so many different diseases. And so we almost always are needing to treat inflammation, and the endocannabinoid system is central to this as well. Was that your question? I think I went off.
Yeah. No, it's okay. A little tangents are always okay. Because I wanted to get just a general overview, emphasizing that medical marijuana is one part of a general holistic program.
Yes.
Not necessarily.
Yeah, you were saying, what else can we do? It's not just cannabis that's going to affect our endocannabinoid system. So stress reduction is a huge part of it. Right. And there's so many things, as all of you guys probably know, that you can do from, actively doing something like meditative things, engaging in enjoyable physical activity, making sure you have plenty of positive social interactions, having lots of touch and skin-to-skin contact, massage, chiropractics, acupuncture, deep breathing, activating the vagus nerve, singing, and all of those things are going to also, affect the endocannabinoid system tone is what we call it. And then there's a lot of different foods that have been shown to also interact with the endocannabinoid system. So omega-3 fatty acids that come from cold water fish, hemp seeds, hemp oil, those are, food products, walnuts, sardines, eggs. Black pepper has a compound in it that binds to the cannabinoid 2 receptor. Olive oil, there's a whole family of cannabinoids other than 2 main ones that we hear a lot about. Chocolate may actually contain one of our endocannabinoids, anandamide. Other herbs are going to have compounds. Echinacea has some compounds that interact with the endocannabinoid receptor. Yeah. And then we know that exposure to plastics in our environment, plastics or plasticizers can be in a lot of cosmetics, body products, everything from deodorants to smell good things. So people really need to be careful about everything they put in or on their body.
Yeah, definitely. And that all lines up very similar to what we talk about a lot. And Invigorate is just this holistic program. So let's dive into cannabis, cannabidiol, everything that I can't say at all. But let's dive into some of the specifics. So from your research or your anecdotal kind of experience in the clinic, because I know not everything is backed up by perfect research studies, how does cannabis play into a Parkinson's plan of attack for someone who's been diagnosed with Parkinson's, who has Parkinson's symptoms? And I can maybe we could go through symptom by symptom to talk about how maybe using cannabis in a treatment program would affect different symptoms. Do you want to talk as a whole about Parkinson's and cannabis first, and then we can hit the symptoms one by one?
Yeah, let's just say to start with, why this endocannabinoid system for Parkinsonism? So the snippy answer is neurobiology. So the biology of our central nervous system, and we were talking about that part of the brain that's responsible for Parkinsonism symptoms, and the cannabinoid 1 receptor is very dense and at play there. And so we know that even though dopamine receptors decline, as disease progresses, we don't know that same thing is happening with the cannabinoid 1 receptor. So it's going to still remain a target. And we know that it has neuroprotective potential. This has been shown in animal models of Parkinson's. Cannabinoids are antioxidant. We know that there is a change in this endocannabinoid tone that mirrors the disrupted dopaminergic signaling. And there's also what we call crosstalk between the two systems, where it's been shown that the cannabinoid receptor and the dopamine receptor actually join up together, and then there's new signaling that happens. So there's a lot of reasons to think about doing it. But in practice, we don't have a ton of evidence on it. So we know from ancient writings, very old history of the use of cannabis as a medicine before it was really prohibited here in the United States in about the 1930s. It was being made by numerous drug companies in the early 1900s. And, one of the things it was touted for was tremor. But the problem with all of those products was that nobody could predict the potency. So, they could have gotten a preparation from anywhere on that spectrum that we were talking about, because the plant was very diverse and we had no way to say this was a red pepper one and this was a hot pepper one. So it kind of fell out of repute because, opium and heroin had been identified in 1864 And so, we could quantify it and say, oh, we know you're going to be taking this much. But with the cannabis preparations, we couldn't say, we didn't even know what the active ingredient was. So we couldn't say, yeah, we know you should take this much. So it was, it wasn't really pursued as a medicine. And then, of course, in our federal government hasn't really allowed, for prospective studies with cannabis. And even to this day, the only product available for research studies is inhaled cannabis. So any of the research that you see about Parkinson and cannabis, probably came from Europe, and it may be from a variety of types of cannabis medicine. It could have been just people smoking cannabis. There's a couple of products in Europe available for study, but really, if you look at the whole body of the research, most of it has been done with cannabidiol.
Okay, which is the CBD oil, cannabidiol.
Yes.
Okay, just to regroup for people who are watching. So is it possible in your practice, and I didn't preface you with this question, but is it possible in your practice when say someone comes to you and says, I have tremor, are you going through your mind and saying, okay, this specific, if we're talking about the range of pepper, right, from our lowest CBD to or from CBD to THC kind of spectrum, mm-hmm. Are you able to say, okay, for tremor, I would recommend more of CBD to THC. I would recommend something that you inhale versus something that you smoke versus something like an oil. Are you able to kind of go through that prescription almost as a provider to structure someone's program, or is it a lot more general recommendation and then experimentation?
I often get pretty specific, and it's not really a cookbook style recipe because I'm taking so many things into account. And I think something that's really important, probably for this patient population, is balance issues or dizziness, and so that may play a big role in ultimately what I recommend. The evidence on tremor is really, really sparse. So, when we're talking about motor symptoms and treating motor symptoms, THC would be the compound. Because at this point, CBD hasn't been shown to have any pharmacology that would suggest to affect motor symptoms. So, I have found it very hit or miss with THC and tremor in personal clinical experience. And then as far as whether it's inhaled or taken orally, a lot of that is patient preference. They're kind of two different characters, really, because if you have the plant material, and I'm not a fan of vape pens at all, and I tell people to just say no to vape pens. And there's a lot of reasons, contamination issues, pesticide accumulation. They're just harsh. They're too concentrated, and they're easy, I know, but we just don't have enough evidence to say they're really safe or efficacious at this point. But using a vaporizer with the whole plant, where you get all of those compounds, the terpene compounds, everything that you smell. It's like taking an IV in terms of the rapidity with which it gets into your bloodstream. It's there within minutes. And that's, I know, I've seen the videos of people with Parkinson and severe tremor where I know one guy takes a big bong hit right on the video, right? And you visibly see his tremor just dissolve. And, there may be sex differences. There's just so many individual genetic differences that we don't know yet how to predict who might benefit and who might not. But I think inhaling with THC is probably the best way to get to motor symptoms. And it doesn't have to be the habanero pepper type of THC cannabis. It can be even really low dose, but as long as there's some there, it's going to have more impact on the motor symptom than CBD.
Okay. So can you walk us through when you say low dose THC and inhaled, is that a specific strain? I'm assuming that's a specific strain that's lower compound
Well,
THC, or
in
how does that measure?
California, in California, we have access to so many different, I call them chemotypes. I know the strain is like a common name that people use, but that term has never been used in horticulture. It's used
Okay.
to describe bacteria. So, yeah, you would have to have, a chemical analysis where you could see how the percent, it's usually the percent of CBD or THC. And so in California, we have those analyses. And you can look and see, is it 16% CBD and 1% THC? So, that's one that I have access to. And I may start, if people are going to inhale, that would be like a starting dose. Or the chemotype to start with, and they can add THC by pinches to increase the THC content. So typically people are just doing a self experiment, where they start at a really low dose, and then they can it's like making enchilada sauce, where you put a tiny bit of chili powder and it's not hot enough yet, so you add another pinch. And
Okay.
so using a THC chemotype, you can add it pinch by pinch like that. So that's a self-titration model of inhalation with the flower type.
Okay. And is that breakdown percentage-wise only available when you are getting medical marijuana? Obviously, a recreational marijuana, somebody probably doesn't have the breakdown of, what they're inhaling or...
Well, in all the states that are legal, they all came with quality control regulation. And so I believe all of the states that have passed medical marijuana laws or even recreational, nothing can be sold at the retail level unless it's gone through that testing and labeled for potency. So there's no differentiation in the marketplace between a medical product and a recreational product. It's just cannabis products. And I differentiate them because there are some products where people can get that low dose. Most of the recreational product, it's like 10 milligrams and whether or not you can divide that and get a lower dose or not depends on the product type.
Okay. So when you say low dose, what is that? Is that a percentage? Is that...
So when you go to an extract now, like a oil, a CBD oil or a cannabis oil, that term oil is kind of relative because extractions can be done many different ways, and it's important how they're extracted because a lot of times if they're heat extracted, then all of those terpenes are lost, and so the product really gets reduced now to just the cannabinoid content. On the other hand, they may be saying the terpenes are still there, and so they may call their product a sativa or an indica. And this is based on some old nomenclature or old naming, and this is all in the process of being rethought because we know so much more now by looking at the entire chemical composition. That when you go to an oil or something that's going to come, in a bottle like with a dropper, then this is usually going to be milligram dosing now. And so, that's where I start. And so with THC milligram dosing, sometimes I start people on half a milligram, literally, or a quarter of a milligram, because I just have a sense that they're very sensitive, or they may tell me they're sensitive. They may have balance issues, dizziness, and we don't want to provoke that. And often, if somebody has a pre-existing dizziness or balance problem, my experience has been that it may exacerbate that. So being very careful. And then, it depends. Again, like for nighttime and treating sleep, that could be different dosing from the daytime. So I was really talking about THC in that milligram dose at that point.
Okay. Yeah, we're in the THC for motor symptoms, which when we say motor symptoms, you're referring to something like tremor, rigidity. What other motor symptoms have you found THC to be helpful with?
spasticity, but I mean, that's not as big of a problem in Parkinson as it is in MS. I have
dystonia?
one of my...
Sorry to interrupt. Dystonia?
Potentially dystonia or dyskinesia, maybe, because I think they're related. The other cool thing about THC, and I don't think the same data exists for CBD, is that it's been shown to cause a release of dopamine. It's not like most drugs of abuse, like cocaine, something that people get really addicted to. Part of the reason for that addiction is this dopamine flood that happens in the brain. And that's just this overwhelming sensation of just feeling so good and hyper, and you're on top of the world, and you can do anything. And we know that THC has a similar effect, but it's not a big flood like that. It's more like just this little trickle. But it does contribute to this overall sense of well-being and, feeling better. As you go up in dose, that can change. It's what we call biphasic. So at low dose, THC can reduce anxiety. At high dose, it might cause anxiety. And so this could be true for any of the motor symptoms. So I've had some Parkinson patients who tell me that their symptoms actually worsen when they try THC. I've had some say they worsen even with CBD. So it's so individual, and everybody's really different.
Okay. Yeah, that's very true about all of our people diagnosed with Parkinson's. Everyone's unique. And so I want to take a moment here to also say to everyone watching, this is not medical advice. This is a general conversation around medical marijuana. So if you are interested in trying any of this stuff for yourself, make sure that you are doing it with a qualified healthcare team, which we'll talk about here in a little bit, but just to plug that in here. So we talked a little bit about motor symptoms, and now maybe we could switch into non-motor symptoms for Parkinson's and maybe what that might look like. So things like pain, obviously. Let's just start maybe with pain, and then that might come with rigidity. That might come with some of the motor problems, but it sounds like that's a background that you have. So can you speak a little bit about how you go about constructing a program for someone who is having pain as one of their primary symptoms?
So for pain, a lot like the motor symptoms, THC is the go-to molecule for me again. And this is because we have a lot of evidence. I'm a very evidence-based practitioner. And so I go to the clinical literature, I read it all, I try to synthesize it and see how does it apply to my patient population. So we have really good data showing that cannabis containing THC can be effective for neuropathic type of pain. And these have mostly been smoked or inhaled cannabis. So I think this is a bit of I call them urban legends. So, a legend around CBD is that you can take it and get all the benefits of cannabis without the THC. That if you think about what I said in the beginning, that they share no pharmacology, then you can understand why this is really not true. But you'll see it over and over again about CBD. It's still cannabis. You can have all the benefit and not be high or stoned. My clinical practice is really heavily weighted with pain patients. And I can tell you from experience of around 300 patients now, CBD does not treat their pain. I think another thing that's happened, THC is a really potent molecule. So 1 or 2 milligrams, which is a really low dose, can be very effective for a lot of people. Too effective maybe for some. CBD at 2 milligrams is not going to do anything. It's never been studied at that dose for anything. So like the products you see for CBD might be 5 milligrams in a spray or 20 milligrams in a capsule. I rarely see anything higher than that. And I've asked these companies, how did you arrive at that dose? Because if you go to the medical literature, nobody's ever studied that dose. And even in the Parkinson literature, the lowest dose of CBD that's been studied was 75 milligrams. If we look at effects on anxiety, psychosis, hundreds of milligrams, which really makes it unaffordable for most people. So until we can have cannabidiol in dosing that's relevant at an affordable price, THC is really still the go-to molecule. And so for pain, again, that low dose of THC with a very slow titration to tolerance. So you're looking for the best benefit with the least amount of side effect. And I think that a lot of people get hung up on that side effect because there's been so much stigma around, like I was just saying, and what I hear patients say, well, I don't want to be stoned, or, well, I don't want to be high. And so I ask people, what does that mean to you? Let's talk about that, because you're on opioids, are you high? And so it's often just a stigma, and they'll describe the way people might look, and that, so they don't want to be associated with that. So I think there's a lot of stigma around that, and I think it's really probably keeping people back from some of the benefit of the whole plant of cannabis by still, identifying with that stigma about THC, because it's a very important, powerful medical molecule.
Yeah, there's no judgment passed in this broadcast of doing it or not doing it, but I do think that that's valid, investigating the stigma and why you feel the way that you feel. So let's continue on with the non-motor symptoms. I'm seeing everyone's questions coming in too. Lauren, who's moderating this, is collecting them, and we'll get to them. So stay tuned. We are gathering your questions. But as far as non-motor symptoms are concerned, the next big one that, there are three. So we've got anxiety, we've got sleep, and we've got appetite. So maybe we can kind of run through those when you have someone come to you. What's your mindset around maybe anxiety to start with?
So I think cannabidiol can be effective for anxiety. Again, we're not really sure of the dose. And, if you're just buying product off the internet, you can't even be assured that the dose that it says it is actually what it is. The dose that was associated with decreasing anxiety was in a study of public speaking, and that was a 400 milligram dose. Wow. And again, so this was isolated CBD, and we have a little bit of evidence suggesting that when you take it in the context of the whole plant, you may not need as high of a dose as these drug studies where they're using just the isolated compound. So I have people I usually start people on maybe 25 to 50 milligrams a couple of times a day, and avoiding it after evening. I wouldn't use cannabidiol for sleep, except during the day. Not to sleep during the day, but there's some evidence suggesting that taken early in the day might improve sleep at night. But CBD is thought to be alerting, not like a big stimulant, but just cognitively clearing things up. So I think for anxiety, it can be an important one. But again, avoiding it late in the day, so maybe taking it twice a day. I usually say 8 a.m. and 2 p.m. And then sleep. So I have the best success with THC for sleep at night. I have a really great protocol using melatonin along with THC dosing at night, and have some great success stories from patients, even suggesting that due to improved sleep, their tremor during the day is better. So just by treating sleep, we can improve so many symptoms in many, many diseases. And often people aren't even aware of how poor their sleep quality is. So, and sleep behavior disorder as well.
Apnea and Can I ask you a question? Oh, sorry. Let me back you up 1 second, because you said you combine THC with melatonin. Are those both in the liquid? Well, THC would be inhaled, I would imagine, and then melatonin.
No, I usually give the THC oral at night, because when you take it orally and it's going through the digestive system, our body makes a metabolite, and so you get a much longer effect. With inhalation, there's not a lot of that metabolite, and the effect is usually gone by a few hours. But with taking it orally, you can get a longer effect. So I have them getting a melatonin supplement, and then the oral cannabis preparation at night that contains THC. So the research on sleep is 2.5 to 10 milligrams of THC at night. Again, sometimes I'll start people on a much lower dose. I have a patient with restless leg syndrome, which is, it's a dopaminergic motor problem. Right. And she was very scared. And so started out with a little tiny dose. And when she finished up that product, I had her switch over to the one I usually use, where the starting dose is 2.5 milligrams. And she was going to try to take half of it, but accidentally got the full 2.5. But emailed me the next day and said she had the best night of sleep she had had in a long time and slept all night and felt great. So, if people are afraid of it, nighttime's a good time to start it, because you're going to be asleep anyway, and you may need help with sleep. The sleep behavior disorders. There was a trial of cannabidiol, 300 milligrams. It was only 4 people, 6 weeks, and they didn't really show, huge effects. It was a small, case series that they did. So then they went on to do, there's been some trials of 300 milligrams a day of CBD. And the results just haven't been that mind-blowing, that patients are reporting, improved quality of life. They couldn't measure anything showing there was neuroprotection. The scoring on the UPDRS wasn't affected significantly by taking CBD. And again, that was 300 milligrams a day. So a lot of people can't even afford that. It was tried for dystonia, CBD at 100 milligrams a day, increased up to 600 milligrams a day, but there wasn't any effect on dystonia shown. But nobody had worsening of symptoms or side effects. What else? The tremor one is interesting. It hasn't really been prospectively tried, but some people report a reduction in tremor. So like we started out saying, there may be some, population that's going to get the benefit, and we just don't know how to predict who that is. I think another thing that comes up is psychosis, sundowner syndrome. So psychosis, CBD has been the one more studied. THC at high dose can actually cause psychosis.
Can I ask you about that? Because I have heard in my research that taking THC, if you have a cognitive impairment to start with, it's not recommended by a lot of physicians to use medical marijuana in your treatment program, because you are at risk for further decline. Can you maybe speak to that a little bit?
I don't think we have any evidence for further decline. I think, again, it just comes down to individual patients so much, because like with agitation and severe behavior problems in patients with Alzheimer's, and so here we could be talking about atypical Parkinson, actually giving, a particular dose of THC can really calm people down. And I think often when we talk about using THC, people just immediately go to that habanero type, because that's really all that's been studied. And that's where all of this negative talk we hear about it comes from, is only studying it as a drug of abuse with harms and dangers. We're getting ready to publish a study on effects, where we asked cannabis users about effects. And interestingly, the older population, so they were greater than 50 years of age, reported less negative cognitive effect than younger people. So we don't know why that is. It could be changes in the brain as we age. It could be that as we get older, we're already forgetful. So if cannabis makes us a little more forgetful, it's not that big of a deal. Because usually those effects are short-lived. They're transient. They don't hang around once the drug wears off. And as far as permanent damage, there's never been any evidence shown that either THC or cannabidiol harm neurons.
Okay. Yeah. I think someone just asked this question, so it just came up. The neuroprotective benefits, you've said it doesn't harm neurons. It actually potentially could be neuroprotective, protect and decrease inflammation. So that's wonderful.
That's part of the antioxidant effect. And this has been mainly, it's hard to measure this in humans, but it's been measured in animals where we can measure, oxidative products. And how using cannabinoids, whether it's our endogenous compounds or the cannabis compounds or other synthetic molecules that have been developed, that we can reduce the burden of these reactive oxygen species. So, you got to think of antioxidants like shock absorbers. We have oxidative damage happening all the time. And we need all the shock absorbers we can get. We all need that. But if you have Parkinson's, that's really associated with, this active destruction of neurons. And so the brain is constantly needing to clean all that up. You want every kind of antioxidant on board that you can get. And that, CBD may have that effect. We don't have, with a disease that progresses slowly over time, it's hard to study. But we hope, using a combination of lots of things that we can slow progression.
Yeah, this is great insight too. And I know that you you said that you were working on publishing, but you did a quality of life survey with Dr. Mishley, I believe. And I read that it overall, the survey came out essentially and said that, was this specific to Parkinson's, or did this include different neurological diagnoses?
It was just a survey of cannabis users. And so that data set was the users who identified only as medical users. And so we said, what are you using it for? How effective do you think it is? And what's your quality of life? And so that was basically showing that people using cannabis, their quality of life wasn't worse than the general population. In fact, they were medical patients, and they scored almost on par with healthy subjects in terms of their quality of life. Yeah. So I don't think there's any fear of destroying the quality of life by using medical cannabis.
Yeah, which is a true fear from a lot of people who have heard information about, marijuana is a drug of abuse. It's a gateway drug. If you take it, you'll get stoned and you'll just fry your brain, all the good things that I know that I learned in DARE class.
Yeah, we call that propaganda.
Yes. And so I think that time is evolving and, things are changing. And so being informed, you can choose to participate or not, but inform yourself and try to identify your biases. So we have been going for quite some time. I want to keep diving into some of these questions because we have a lot from our audience. And actually, let me look at
How long are we going? Till 4:30?
It's usually an hour. So we're supposed to have about 5 more minutes. So I'm going to dive into some questions. And maybe we can try and be as succinct as possible so we can get in a lot, because I have a lot of people submitting their questions. So number one, we've got this one from David Dorsey, and he asked, what specific strains do you recommend for muscle spasms? I know strain, we've decided, is not the best word. He says he's had some success with ACDC, a CBD dominant strain available in flower, and that has a very mild euphoria. So maybe we could just back up to the core question, which is specific advice for muscle spasms.
So, the short answer is always go for less THC rather than more. If you can find a chemotype containing CBD, it's going to have less THC, and aim for, about a 5% THC content if you're going to be inhaling. So there is going to be some of that euphoric part of it, because that's the THC and that's the antispastic compound.
Okay, that's a great answer. So 5% THC component if you're inhaling for some of those muscle motor symptoms. Sorry. He also had a second part to his question, which we may have to table because it kind of goes off the beaten path, but it says, as medical marijuana is recommended treatment for many conditions, what's your opinion regarding the legislation of reasonable THC levels in patients who are employed and or still drive a vehicle?
Yeah, that's under debate. It's being studied here at the Center for Medical Cannabis Research at UCSD. So they have an active driving study going on. And so we're really trying to determine, is there a number that can predict impairment or not, or is it too variable across humans? And does tolerance develop? So can people, just like they do when they're taking benzodiazepines or opioids or gabapentin or other drugs that can affect cognitive function, use your own best judgment. And there are people out there driving on a lot of those drugs all the time. And so we know that people may gain tolerance to those negative effects and still be able to drive safely. But this is something that needs more research, and it is being researched.
Okay, that's great. So follow, where was that, USD?
Yeah, UCSD has a Center for Medical Cannabis Research, CMCR, and I'm not sure when those results will be in, but they're hard at work.
Great. Okay, Bettina Kelly asks, my boxing instructor asked one of the men who smokes marijuana for Parkinson's not to do so before class for safety reasons. How does smoking and exercise work?
I think they go together really, really well. I think, again, it's dose related, but if it's someone who's, used to their own dosing and they know what they can handle, I think it's a little irresponsible to tell them to just say no if they can handle themselves. THC may be activating stretch receptors. And another thing that it may do is increase the strength of muscle contraction, because acetylcholine is another neurotransmitter that is released. And that's the main neurotransmitter at the nerve muscle junction. And so I have a lot of patients that actually use it for exercise enhancement.
Oh, okay.
I've always wanted to do an exercise class and call it stone play, where people actually, we ask them to get stoned and come in to exercise, because we think it actually facilitates movement and coordination in a lot of cases.
Yeah, I play a lot of soccer, and I have a lot of soccer friends who would definitely attest to that testimonial there. So then we have Arcana. I'm sorry if I'm mispronouncing your name. Is there a chance of addiction? And we talked about pain. She had another question about pain. So is there a chance of addiction?
I would say there's a chance, probably like with anything. There are people that have more addictive type of tendencies than others. And so because of the feel-good effects of cannabis, I think that population could have a similar experience with cannabis. In our survey that we're getting ready to release these results, when asked if they had difficulty stopping, the majority said no. And if you asked by age group, older people were more likely than younger people to say that it is not addicting. So changes in the brain over time probably have a big role, and we need to know more about all of this. But in terms of, addiction, what we often look at is withdrawal. And so we know that withdrawal from cannabis, if you're a heavy chronic user of THC, you can have some withdrawal symptoms, but they're very mild compared to other drugs. And this endocannabinoid system that could have been hammered and, causing those withdrawal effects, because it's a system of homeostasis, it bounces back really quick. So that withdrawal is short-lived, and there's not a lot of drug craving that seems to go hand in hand with it.
I think that's a big fear of a lot of people who are considering, as you probably know, a fear of getting addicted. So, all right, let's see. Miss Bonnie Robson, she submitted a question, and I think we probably addressed it earlier. It's about pain and tremor, but I'll read it. And if there's anything additional you want to add that we haven't covered yet, you can hop in. But she says that she has a lot of hip and leg pain, especially at night. and tremors becoming worse. Does medical marijuana help with those problems, which we know is potentially yes? And what are the side effects, which we talked about a little bit? Is there anything additional that you wanted to add that we haven't covered?
I think, if you're using it at night for pain, the side effect is going to be less pain and better sleep. I mean, the only thing I caution people about is, again, if they have any kind of dizziness or unsteadiness, if they get up in the night, to use a walker, or if they use any kind of assistance, to just be sure and use it until they really know if it's going to worsen their balance issues. If they're a fall risk, being extremely cautious. But yeah, for sleep and pain, THC is my go-to and not the CBD.
Okay. All right. I'm going to scroll through the comments here. I'm going to pull someone's question up. We've gotten a lot of comments. You guys are all saying hello. I love seeing you guys in here. Let me ask the question, then I can maybe find it and pull it up. But let's see. Roger Jenkins asks, how do you verify quality, and what is the shelf life?
Well, I don't know if this is in an illegal state, because again, like I was saying, in states where it's legal, there's pretty much quality control testing that's required. But even if you're ordering something online, I would request to see the certificate of analysis and see if it's been tested for, mycotoxins. So those are things that mold or fungus can make that could be dangerous. Just bacterial contamination, pesticide contamination. There's a lot of talk about heavy metals, although we haven't actually seen a lot of heavy metal contamination yet. But I usually ask the companies, I would like to see your certificate of analysis, and you want to know that it comes from a third party, not that they're just testing it themselves and telling you, but they've asked someone else to test it that's reputable, that's given that result out.
Okay, that's a great input. He's in Indiana. I'm not sure actually if it's legal there, but we know Roger from way back. I'm so glad you're here, Roger. All right, so then Teresa asks, and she says, which is better for symptoms of Parkinson's, sativa or indica cannabis? And I know you said strains are kind of the wrong term, but maybe you can clear up some urban legends?
Urban legends.
Urban legends.
Yeah, so those designations, sativa and indica, were originally based on the way the plant looked when it was growing. So a sativa was one that was tall and had skinny, narrow leaves, and an indica was usually a bushier, fatter leafed plant. And now, because there's so much hybridization, we know from a number of analyses that have come out of California, because it's been legal here for a while, and we've had laboratories doing analysis, that you can't really separate them out. Even if something's called a sativa or an indica, if you look at the complete chemical profile of all of those smelling molecules called the terpenes, plus the cannabinoids, there's not a lot of differentiation. And so the hybridization has really caused loss of biodiversity. And so while those terminologies are still widely used in the popular culture, if we were going to, use that from a medical perspective, we don't have the answer of what makes it a sativa or an indica. I have my own suspicions. And so in terms of the question, I can't answer it. I usually go with a plant chemotype that has pinene content, because pinene is a really potent antioxidant, and it may also inhibit the breakdown of acetylcholine. And I think that I just love acetylcholine, and I think it's good for lots of things: cognitive function, muscle strength, immune health. And so it may be, what effect are you looking for? And there's definitely those ones that are going to give a heavy body and more of a sedation feeling. And right now, other than asking the bud tender and taking somebody's word of mouth recommendation, we don't have a way of really delineating those things.
Okay. Hopefully, Teresa, that answers your question. All right, we've got, this is a quick one, I'm sure, but Susan asks, good point with stress, and can you use cannabis as an alternative to Xanax?
So I have a lot of people that are, trying to wean off of benzodiazepines, and they're hard for some. They're really, really hard for some people. And I've had a couple of patients with extreme anxiety in their Parkinson disease, and so using a mix of the CBD and the THC in terms of cannabis. I mean, I have other add-ons that I'll often use with patients because it's not always straightforward. But low dose THC is going to be really anxiolytic, or can treat anxiety. So again, 1 to 3 milligrams, really low dose, and then as high of CBD as you can afford.
Okay. And you said sometimes you use add-ons. What does that mean, add-ons?
Just, other things to treat the whole person. So I'm, looking at their diet, their gut function,
okay.
Their microbiome, because we know that like a ketogenic diet, it was just published that ketogenic diet may actually increase GABA production in the brain. And this was a mechanism of how it's treating seizure. But more GABA in the brain, everybody should want.
Mm-hmm.
So, diet and probiotic foods, prebiotic foods, using N-acetylcysteine to boost glutathione, so you just have more antioxidant protection, lithium to slow down dopamine transport, sometimes other herbal combinations. So, there's other options, and sometimes you have to throw everything at somebody.
Yeah, definitely. Okay, great answer. Are you okay if we go a few more minutes? Are we keeping you from?
Yeah, I can do a little bit. My computer battery's getting pretty low, but I think we got a little bit of
time. Okay. We've just got a few more here. Barbara asks about how does this help with mobility? She said she joined late. So Barbara, we talked about mobility and motor symptoms and cannabis at the beginning of this broadcast, pretty in depth. But you did ask about freezing. And so we didn't talk about freezing. Have you had any clinical experience working with people who have freezing episodes, and what's been their outcome?
So no, I have not had anybody with that particular symptom.
Okay.
Is that related to the dyskinesia, or is this something different?
It's more of a sensory motor. Yeah, it's they'll report often that their feet feel like they're stuck to the ground, especially when they're anxious or, in crowded situations. It happens a lot in like narrow hallways, going through a door.
Okay.
It's kind of
Okay. So that could be a cerebellar effect, I guess, where you don't really know where you are in space, and so that's why you kind of don't want to go through the doorway. Am I getting that right?
It's more of a proprioceptive dysfunction. Yeah. So
So that would be the cerebellum.
Right.
So again, I mean, that's what I kind of worry about that with THC.
Mm-hmm.
But, it's totally untried. And I mean, we need so much research, honestly, because we have nothing else for these things. So we really need the doorway to open that we can really prospectively go and take a look and find out, is this going to help or harm somebody with this symptom?
Definitely. And I will say that I've had clients here in Texas that have procured cannabis from some friends. And if their freezing is specifically exacerbated by stress and anxiety, they do fine until they just get really anxious and stressed out. They have reported that it does help them get out of freezing episodes a little bit faster. And it's probably, from their perspective, they were feeling less anxious and less stressed, which can help improve
that makes sense.
Freezing at all.
Yeah, treating the anxiety and then having the unanticipated effect of it helping other symptoms.
Yeah. All right, let's see. Mammy says, what about hemp oil to rub on your body where the pain is? I haven't heard of this.
Yeah, so that's a question I get a lot because, a lot of people are wanting to avoid any psychoactivity. They don't want to take anything orally or have any risk of, having any effect of a THC. But I'm not sure if, Mamie, if you were here earlier when we were talking, but there's no proven way that CBD is a pain reliever. And so my personal experience is that a lot of my patients come and get referred to me for pain, and they come having already tried a topical preparation. And I personally have not seen it be effective. I think it really depends on the type of pain. If it's a minor musculoskeletal, inflammation, it may reach the site, but for neuropathic type pain or neuralgia, we really think it has to be given orally and systemically to affect that type of pain. And not CBD. We have zero evidence in humans that CBD is an analgesic. So it may have some anti-inflammatory action. And so if there's a strong inflammatory component to pain, people may get some benefit. But again, nerve pain, neuropathic pain, neuralgia is really more receptive to the THC compound.
Okay. You are making this very easy to understand. I love it so much. Okay. Yeah. All right. Norman asks, are dosages at any level a danger to Parkinson's people in recovery? So people who are working on improving their Parkinson's symptoms, getting better, healing their body. Are there any dosages that are dangerous?
Well, what does in recovery mean? I'm not sure. Are we talking about recovery from addiction or recovery from?
Oh, I don't know. I made an assumption that there are a lot of people in the Parkinson's community that say they're in recovery from their Parkinson's diagnosis, just as like a way to talk about but I actually don't know. Maybe you could talk about recovering addicts, or maybe you could talk about that.
I know a lot of people have concern about it, if they're in AA or if they were ever even a tobacco smoker, they have a idea that, this could be really, really harmful. But there's another idea that of a concept called harm reduction, where cannabis and the amount of harm that it may cause is so much less than other drugs of addiction that if cannabis can help people get off of tobacco or decrease their alcohol consumption or cut back on their benzodiazepines or their opioids, that it's a harm reduction approach in that there's less harm that could be caused by the cannabis than other drugs, and maybe, a good level of benefit to boot. So if that's the kind of recovery we're talking about, it's becoming trendy here in California. There's actually an addiction recovery center that uses cannabis to withdraw off of drugs. So, the mindset's really changing around that. But if you're just talking about recovering from Parkinson, I don't know of any danger other than what I've already talked about, like fall risk or worsening of symptoms that could create a fall risk.
Like low blood pressure, I know. If you already have low blood pressure.
Well, that's more enhanced with inhalation and with higher doses of THC. Taking it orally hasn't been shown to cause a rapid blood pressure drop. But if people are hypotensive, I do tell them to be alert that it could enhance any hypotension they already have. Okay,
great. And Susan asks, what about effects to address fatigue, which we didn't hit on?
Well, when I think about fatigue, the first thing I think about is what's happening with sleep. Are you getting good quality of sleep? Because we have, what's called an ultradian rhythm at night, where phase 1 is falling asleep. That should not take more than 15 minutes. You go into stage 2. That's where these sleep behavior disorders occur. So that's the part of sleep where you could still be awakened easily. And then there's stage 3 and stage 4. And we know that Parkinson patients often have really severely reduced melatonin levels. And so by giving melatonin with THC at night to get people into those stage 3 and 4 sleep and stay there can really address fatigue and narcolepsy during the daytime.
That's wonderful.
Yeah, and I would start there with fatigue. Start by treating sleep. If you've already done that and you still have a lot of fatigue, I mean, you might benefit from, a consultation with a naturopathic doctor or a holistic or functional medicine type doctor that's going to look at a lot of different things like chemical screens, your blood count, omega-3 fatty acid levels, your homocysteine, your iron, thyroid function, DHEA sulfate. There's a whole host of things to look at to determine where's that fatigue coming from and where do we need to supplement.
Yeah. And so I have a lot of thoughts, follow-up questions, but one of them was Norman, I've got a whole list of people asking questions. It wasn't Norman, it was Paul. Paul Cordell asks, he's very vocal in sleep. So if you're saying that THC and melatonin can help you reach the deeper levels of sleep, I would imagine that would help with some of these sleep disorders like you were talking about.
Yeah, I think being vocal is a stage 2 sleep disorder. It's part of, sleep behavior disorder. So that's where we think there can be some value. I've got a couple of SBD patients right now, that I'm waiting to hear back from. We've developed a collaboration with the Sleep Center at UCSD. So now we have patients going in for a sleep study before and after starting the cannabis. So we're going to really start to get some better data. The studies that have been done were on sleep apnea. And so that can be a central effect from opioids. It can be, a mechanical one where your airway is just collapsing and causing snoring. But either way, there was improvement shown with THC 2.5 to 10 milligrams at night. And again, using that slow upward titration to get the effect you're looking for without, grogginess in the morning.
Awesome. Okay. We've got Allison who asks, I'm in the UK and have Parkinson's and epilepsy. How do I gain marijuana here to help me? And I think this can stretch into a broader question of what do people do when they're somewhere where it's not available? Well, I'm sure it's available, but it's not legal in any capacity. What recommendations do you have for those people?
Well, in the UK, there is Sativex. So, that's a drug that's available by prescription, and it was approved for multiple sclerosis and not Parkinson disease. But I don't know if it's easy or difficult to get in the UK, or if they can use it for different indications. The same pharmaceutical company, GW Pharmaceuticals, has another drug called Epidiolex, which is a pure CBD preparation, and that's specific for treating epilepsy. It just got some approval here in the United States for certain intractable epilepsies. But sometimes when those drugs are on the market, doctors can use them, off-label for other symptoms. And if you want to go with something that's more of a whole plant, people are just finding local networks, and it really seems to be exploding all over the globe. Honestly, I talk to people everywhere. I had a visiting doctor from Peru last week, and it was being legalized for medical use in Peru beginning this week. And, already the patient connections are there and the growers are stepping up and there's product available, even though the country hasn't sanctified it or, created the regulations around it.
That's good. Super, super information. Hopefully, Allison, that answers your question. Let's take that guy down. So that is all for our questions. And so, Michelle, I wanted to say thank you for joining us. I appreciate you going a little bit longer than we planned. Can you maybe tell people where they can find you? Or I know you do telemedicine consultations. I know you can't take people on who are outside of California as patients, but you do have some ability to consult on the topic. So where can people find you if they want to learn more?
Well, my website, I have a Facebook page, Michelle Sexton, ND. You can go like me on there and keep track. And then my website is msextonnd.com. So that's ND for naturopathic doctor. And you can schedule directly on that site for telehealth consultation and or give the office a call if you have other questions or want to do a brief 10-minute question and answer session before deciding if you want to schedule.
Perfect. All right. Well, you guys use her website. And if you're watching and you're having trouble keeping track of all of this information, you can find links to all the resources that we mentioned in the description, depending on where you're watching, above, to the side, or below this video. And I would love to know, for all of you out there, what you think. What have you learned? Have you changed your opinion about using cannabis or medical marijuana in your Parkinson's plan of attack? Are you already using it, and what have been your effects? I would love to hear, and I'm sure Michelle would too, in the comment section below. And as always, if you found this beneficial, you can go ahead and like and share this video with anybody who you think would benefit from learning more, which we all have an endocannabinoid system. I couldn't nail it at the end. And so we would all benefit, right, from learning this information. So again, Michelle, thank you so much for joining us. I really appreciate all this information and for all the work that you're doing to just improve transparency and decrease those myths that are out there. So thank you so much for joining us.
You are welcome. And thank you so much for having me. And I hope, I love to learn from patients. So, communicate with me on Facebook, message me if you have a different experience, because I don't know everything, and the patients are the teachers.
That's so true. They're my best teachers too. All right, everybody, we're signing off here. So until next time, keep moving, and I'm sending you lots of big hugs. All right, bye-bye.